I think it's really important when you look at what kind of impacts cardiac has upon cancer treatment that you think about it in a couple of different ways. You have to think that some people come into cancer treatment with pre-existing cancer, cardiac disease. You have to think that some of the drugs are cardiotoxic. And you have to think that sometimes things just arise that are cardiac in origin, but maybe not a true toxicity, but something maybe that is a risk related to a side effect, another side effect. And so I kind of look at it very broadly and say that everyone has some risk for cardiac complications when they come into cancer therapy, and it's up to us as the caregivers to really tease that out.
Cardiac toxicity is sort of on both spectrums of the age range. So somebody that's under 15 years of age is at high risk because, for like childhood leukemia, so to speak. But then 65 or older, also because again, you've been living a long time, that's increasing your risk. That doesn't need to necessarily mean that somebody that's 40 years old is not at risk. And I have seen patients that are in their 30s and 40s that have developed cardiac disease because of their treatments.
There are ways to prevent the impact of cardiac toxic therapy. We know that healthy living is important. We know that not smoking, leading a healthy lifestyle is one piece of it. There's also protective agents, but they've only been really studied in drugs like doxorubicin. And so there is Zinacard, dextrosone, that is a cardiac protective agent. There's some of these agents that we know are toxic that are formulated in a lipid formulation to reduce toxicity. In radiation, we can shield the heart. Now, there is also some really good evidence in the cardiac literature that says that there is a complementary therapy called coenzyme Q10 that could reduce toxicity. So I think that that is not contraindicated in most cancer therapies, and we encourage patients to take it. I think where there are some unknowns, but yet we're getting there, are markers. We are doing a lot of testing in looking at blood markers to tell us, as we're administering these agents, if a toxicity is a higher possibility or not. So the same markers you do for a heart attack, you can do during infusion of some of the toxic drugs. We're doing a lot more EKGs on people, and it doesn't mean we're worried, it means we're monitoring. And then the minute we see something abnormal, we get a cardiologist opinion.
There's a lot of different symptoms that you can look at. Probably the biggest one that people don't even associate with cardiac toxicity is shortness of breath. People think, oh, I'm winded, it's because I'm tired from my chemo treatments, but it can also indicate that there's something wrong with your heart. So that's one. Fatigue. A lot of the symptoms, again, they're interrelated with what's going on with the patient, but they also are symptoms of cardiac toxicity.
You should never ignore any symptom that lasts for more than 2 weeks. And I think if you really look into the literature in heart disease, particularly women are less likely to present with the typical, oh, I have pain in my chest and in my left arm, and they may just have indigestion or tiredness or shortness of breath. Now that becomes really problematic when you've got so many secondary symptoms, or you're worrying potentially even about a cancer recurrence. So I say, in moderation, you know your body and you know what is normal for you, and if it is something not normal for you, talk to somebody and have them evaluate it on a professional level and help you sort that out. Maybe it's nothing, but maybe you'll find something early.